I want to thank the organizers for the opportunity to present to you all today regarding external counterpulsation. My name is Dr. Annie Varughese, and I'm an interventional cardiologist trained at the Texas Heart Institute in Houston, Texas. And before I start, I just want to say what an honor and a privilege it is to come before you all, worldwide audience. And I just want to pay homage to my professors who have helped me along the way, starting with J. Willis Hurst, the father of modern cardiology, and Dr. James Willerson, who was instrumental for me in coming to Texas and training under his tutelage, and Dr. David Fish, amazing interventional cardiology master teacher, and Dr. Zvonimir Krazier, who is such a big part of our conference here today, and Dr. Lance Gould, who taught me about prevention and reversing cardiovascular disease. So and I've had so many other professors. Dr. Heinrich Tatemeyer, really a wonderful father of heart failure treatment. And so on it goes, right? We are the product of our teachers. And so I just want to pay homage to all of them today. Thank you, Dr. Omar Halleck, for allowing me to present today about enhanced external counterpulsation. So I want to start today about talking about coronary artery disease. This is the lifeblood of what we do every day, right? And in the US, over 6.2 million with coronary artery disease. And we know that medication and lifestyle modification are key. About 1.2 million patients undergoing surgery or PCI, but there's so many not amenable to any type of intervention. And we want to focus on these patients because there is a great weight of clinical evidence showing that ECP treatment is beneficial in reducing angina. We see this every day in our patients, right? Increasing their functional ability to just live and breathe and enjoy their life. So the target population for ECP is huge. There's so many patients with angina refractory to medical therapy, and these are the patients that do so well with external counterpulsation. And it amazes me how many of my colleagues worldwide have not heard of enhanced external counterpulsation or have not actually had a patient to experience this. So that's why I wanted to bring this to your knowledge base. There's so many slides in this slideshow and so little time to talk about it, but I want to give you a taste of what external counterpulsation can do for your patient. EECP is covered by Medicare. Many doctors don't even know that, but Medicare has guidelines for this. For patients inoperable or at high risk of operative complications, patients who have coronary anatomy not readily accessible to intervention or surgery. And then, of course, comorbid states creating excess risk with having any type of intervention. And those are great patients for external counterpulsation. The mechanism of action is very simple, increasing coronary blood flow in diastole. The procedure uses cuffs wrapped around the calves and lower thighs and upper thighs and the buttocks, and there's sequential compression, basically in diastole, increasing the coronary flow. And that's the main mechanism of action of the external counterpulsation. 35 hours of treatment, so that means 35 days, 1 hour a day, or 2 hours a day, and that will cut the amount of days, of course. So 5 days a week for 4 to 7 weeks. And the initial external counterpulsation was incredibly barbaric looking, I think, very scary with hydraulic pulsatile chambers. But that was in the 1950s, and Kantorowicz brothers first talked about external counterpulsation with diastolic augmentation. And since then, so many investigators in the 60s and 70s worked on this in cardiogenic shock and acute myocardial infarction. But it was not until the 1980s, because there was this failure to gain acceptance of such a procedure to increase diastolic flow, that the Chinese and Stony Brook, the U.S., collaborated and really brought ECP into the forefront. And there were several Stony Brook publications. The initial one was 18 patients with chronic angina refractory to medical therapy. And they underwent therapy, and it was found that 89% reported no angina after treatment during usual activities, and 67% had resolution of reversible perfusion defects. So that was very interesting to the investigators at Stony Brook, and they took this further and did a 3-year follow-up of those first 18 patients and found that after doing repeat stress volume test to same exercise duration as the initial study, of the 14 patients who showed resolution or improvement in the initial study, 11 remained free of limiting angina. So again, they were seeing that this simple procedure of putting patients on this external counterpulsation led to significant improvement in their angina. They did a 5-year follow-up looking at patients treated between 1989 and 1992, and there were of the patients, 29 out of 33 patients remained alive in this 5-year follow-up study. And they found that the 5-year survival without an interim event of 60% of patients treated with ECP appeared similar to that seen in patients, populations of coronary bypass and PTCA. So this was very striking for these investigators, that ECP had similar benefit to bypass and angioplasty. So that's why ECP is now known as bypass without bypass. And they did a patient response survey at Stony Brook and found that in 60 patients with coronary disease after ECP treatment, improvement of resolution of reversible radionuclide perfusion defects were seen in 86% of the patients who had 1 vessel disease, 85% of patients with 2 vessel disease. So the thought conclusion on this was approximately patent conduit may be necessary to allow transmission of this augmented diastolic pressure and flow. What happens to exercise radionuclide resolution? They found that in 50 consecutive patients at the Stony Brook, about 80% had complete or partial resolution of their radionuclide defect. And that's where it is, right? This is what we do every day. We're looking at their stress test radionuclide imaging. And if we can find benefit in perfusion, that's kind of the mainstay of our therapy in everything that we give them, right, as far as medical therapy. So they found a significant benefit in resolution of these defects. There was the MUST trial, which was the next trial led by Dr. Aurora. And this was a US trial, multi-center. And the MUST trial was done to confirm the efficacy and safety of ECP using scientific method, rigorously sham versus double-blind, sham versus active, and in a double-blind protocol. And this was really to broaden the study experience beyond that initial site of Stony Brook in the US, and to determine the effect of treatment versus placebo. So it was multi-center. There was an even assignment to ECP group or sham group, and 139 patients who had chronic stable angina. And this was done over a several year period. So the effect of ECP was evaluated by exercisability, clinical status, adverse experiences, and they used statistical analysis, of course. The inclusion criteria were the patient had to have evidence of coronary disease by one of the following criteria. So angiographically, or they had had a myocardial infarction, or a positive nuclear stress test, plus a positive exercise stress within the 4-week baseline period. Many exclusion criteria. One that we commonly talk about is, of course, severe heart failure, or severe peripheral vascular disease, or severe aortic insufficiency. So the morbidity profiles were very similar in the active versus the sham group. And what was found was that there was benefit in exercise duration, as well as time to ST depression, but the time to ST depression was of significance. So we saw benefit in the exercise response, Adverse experiences were some skin abrasion or pain or swelling or edema at the site, and more in the active versus the sham, because the difference in the active versus the sham was actually the amount of pressure placed on the patient. And sham had very minimal pressure, but the patient felt as if they were undergoing a procedure. But in the active, there was actually the amount of pressure needed to increase coronary diastolic flow. So we know that we can decrease these adverse experiences definitely by protecting the patient undergoing the procedure, and that's what we do every day when we're doing external counterpulsation, having the patient protect the skin of the legs and the lower torso. So the summary of the clinical results was increased time to exercise-induced ST segment depression comparing ECP to sham, and decreasing the frequency of angina episodes. And that was significant. And comparing to baseline, the exercise duration increased significantly in both groups, and the time to ST segment depression increased significantly in the active group only. So the MUST trial was pivotal in our understanding of external counterpulsation. There was subsequently an international ECP patient registry, and there were 1,213 consecutive patients. So before the treatment, 74% had functional class 3 or 4 disease. So these are really sick patients, 78% having multivessel disease, 81% having bypass surgery or PTCA history. And what happened was very interesting. I want you to remember this slide if you don't remember anything else of this lecture, because it shows significant improvement in the post-treatment patients, going from class 3 and 4 down to class 1 and 2. And that's what we want from external counterpulsation therapy, of patients able to function in their daily life. So this is an amazing slide full of wonderful data that you can take back to your own practice regarding external counterpulsation. So ECP is safe, effective treatment for angina pectoris, refractory to medical therapy. The benefits include an improvement of functional status in more than 70% of patients. And the benefits are both short-term and long-term. So ECP is basically an endothelial treatment. So endothelial dysfunction is a key early event in atherogenesis. We know this, and we've talked about this in our multiple wonderful lectures here in this conference. Coronary endothelial dysfunction contributes to manifestation of stable and unstable coronary syndromes. So we know that endothelial dysfunction can lead to myocardial ischemia, even in the absence of extensive obstructive coronary disease. I tell my patients I'm the endothelial doctor because I love the endothelium. And if we can make a benefit in endothelial function, we have changed the patient's life. And very interestingly now, we know that nitric oxide and COVID-19 are very related with regard to endothelial dysfunction in this world pandemic that we're living in today. COVID-19 begins with acute respiratory distress, it moves to vascular networks, and we see platelet endothelial dysfunction and rapid life-threatening blood clotting. So the SARS-CoV-2 is a thrombotic and vascular disease targeting endothelial cells, particularly in patients with cardiometabolic comorbidities such as hypertension and endothelial dysfunction. The hallmark of this endothelial dysfunction and thrombosis is suppression of the endothelial nitric oxide synthase, and therefore nitric oxide deficiency. And multiple papers have been written now within the last year regarding nitric oxide as an important parameter in the viral S protein host receptor ACE2 co-joining, and therefore critical to prevent viral cellular entry. So ECP can be a consideration for prevention and early treatment of endothelial dysfunction. And the mechanism of action is really increasing nitric oxide production. So there are two levels of benefit: reversing platelet endothelial dysfunction and associated thrombosis, and lowering the viral burden. So this is really fascinating data now, looking at SARS-CoV-2 mediated endothelial dysfunction and the role of chronic oxidative stress. And this was published recently by Chang and Associates. And I want to kind of take you through this, where endothelial cells are shown to be key players in SARS-CoV-2, with thrombosis, atherosclerosis, lung injury, all seen in this infection and inflammatory disease. The mitochondria are regulating the inflammatory pathways via redox signaling. So I love talking about oxidative stress. So the mitochondria have this function of become dysfunctional basically, and causing oxidative stress, initiating, exacerbating senescence or inflammation, chronic endothelial dysfunction. And this activates the feedback loops that perpetuate mitochondrial dysfunction and inflammation. This causes long-term changes in the host redox state and endothelial function. So we see cardiovascular disease, lung injury, and all of this happening in the COVID-19 state. So the potential treatment addresses these chronic conditions and includes antioxidant therapy, such as IV vitamin C, which has been used worldwide now in the COVID patients, as well as enhanced external counterpulsation therapy. And Sackner and Associates talked about this in their publication of endothelial pulsatile shear stress as a backstop for COVID-19. So what is this increased pulsatile shear stress? It's a novel therapeutic adjunct and has potential to increase the nitric oxide as well as to benefit the endothelial manifestations of COVID-19. So in this wonderful diagram here, we see on the left normal endothelial monolayer and on the right SARS-CoV-2 activated endothelial monolayer. So in their paper, they looked at something called the gentle jogger and found that the gentle jogger model increased endothelial pulsatile shear stress. So ECP also provides similar benefit as this gentle jogger model, and they talk about ECP in their paper. A dichrotic notch is shown here, and each aortic pulse, we see the increase in dichrotic notch waveform, adding an extra pulsation there, and this produces this pulsatile shear stress on the vascular endothelium monolayer, and this activates cation channel piezo-1, and then you see increased production of adrenomedulin, activating G protein receptor, activating protein kinase A, thus activating eNOS by phosphorylation and increasing endothelial-derived nitric oxide. So again, it all goes back to the nitric oxide. This pulsatile shear stress also has adjunctive benefits, increasing prostacyclin and TPA, superoxide dismutase, glutathione peroxidase 1, catalase, and produces all of this producing an anti-inflammatory endothelial phenotype. So SARS-CoV-2 activates the endothelium, and this monolayer of endothelium loses its barrier function. So we see increased permeability, reactive oxygen species, procoagulant phenotype, and the bioavailability of nitric oxide is decreased. So neutrophils, macrophages are all stimulated by the virus to produce cytokines. We've heard of the cytokine storm. Well, this is the actual cytokine storm, what's happening at the endothelial level. And we as cardiologists should be on the forefront of talking about this and taking care of these patients during COVID and post-COVID. Nitric oxide is produced by this PSS and inhibits replication of the virus, decreasing production of cytokines. So PSS is a means to widely distribute beneficial endothelial-derived mediators. ECP doubles the number of pulses in the circulation, thereby producing this pulsatile shear stress. It's one of the best ways to increase pulsatile shear stress. The increasing release of plasma nitrite and nitrate into the circulation, and even glycemic control in type 2 diabetes is seen as an added benefit of the ECP PSS. So PSS potentially prevents or minimizes aspects of COVID-19. Viral replication is decreased, hyperinflammation is decreased, the cytokine storm is calmed, non-cardiogenic pulmonary edema, myocardial injury are improved, endothelial dysfunction is improved, coagulopathy is improved, oxidative stress is improved, and therefore we see suppression of the ACE2 receptor activation. And Libby and Lucier characterize COVID-19 as an endothelial disease. And that's why I want you to have these take-home pearls of these several wonderful statements. I just want to read them to you. Enhanced external counterpulsation is considered valuable. It's an alternative for patients with coronary disease and refractory angina. Up to 80% of patients who undergo ECP therapy have positive response. And ECP is associated with immediate increase in blood flow in various vascular beds, including the coronary arteries. As we increase the blood flow, this translates into enhanced vascular shear stress, major stimulus for endothelial production and release of nitric oxide, and a key factor in endothelial homeostasis. And improvement in endothelial function is considered as a potential mechanism involved in the clinical benefit associated with ECP. In support of this hypothesis, ECP treatment was shown to be associated with both an immediate and a midterm increase in plasma levels of nitric oxide in patients with coronary disease. Moreover, it's been proven that ECP exerts both immediate and prolonged favorable effects on peripheral endothelial function in patients with symptomatic coronary disease, and that was our Stony Brook and Must data. So there is emerging evidence of ECP influencing PSS and therefore benefiting endothelial function in combating COVID-19. So I challenge all of you to learn more about external counterpulsation. It's the wave of the past and the wave of the future, and especially in our current pandemic situation. Thank you for this time, and enjoy the conference.